you don't have all the time in the doctor's office. As much time as I spend with folks, it's always sort of like, oh yeah, that one thing, right? When you're leaving the doctor's office. And Parkinson's, you know, people sort of joke in my clinic, how come you have the hardest patients? How come you're taking so long in the clinic? And I'm like, well, actually, do you know what it's like to be a Parkinson's disease doctor? It's kind of like a primary care doctor, because you're dealing with, I hate to say it, not just the brain and the spine, you're dealing with literally everything there is. So sometimes I feel like I'm a gastroenterologist or a psychiatrist or a dermatologist, right? Because Parkinson's affects pretty much everything, okay? Only once in a while do I say, that's funny, I think we can probably blame that on something else, but most of the time, it's the other way around. So anyway, I'm Louisa Solis-Cohen. I'm a movement disorder neurologist, which means that I'm a neurologist who has extra training in movement disorders. And most of the time in the outpatient world, I'm seeing Parkinson's or tremors or folks who have unusual sorts of movements and walking problems. And that's what I do. I practice in Littleton, Colorado. And this is about you guys. So this is not about me talking. I can talk for really long periods of time without breathing, but this is about you. So feel free to raise your hand or call out, or if you don't feel comfortable with that, write a question on your paper there. We can put a place together for you to drop it off in the break, and I can try to get to those too, but I'm very happy with being interrupted. Also happy if I can advance my slide. There we go. Okay, so normally I talk about the Parkinson's medications, and instead, thank you for the new task of just do the whole thing in 2 hours. So we have to acknowledge that everything's gonna be a little bit more brief, okay, and more of an overview for you. So some things will be more superficial than you may like, and I'm open to going into more depth wherever you guys feel is more appropriate. I'll keep track of time a little bit, so if we don't get to the halfway point by 5, we may just want to break there anyway. But we're going to talk about the what is it, why is it, how is it, these motor and non-motor symptoms. We're going to talk about treatment sort of options, exercise, medications, and other advanced things later on. Okay, so it's always important to start with, like, what is Parkinson's disease? And I don't even know if anybody knows where the name came from. Dr. James Parkinson, I think it was 1817, yeah. This very astute physician wrote an essay called The Shaking Palsy. And only years later was he acknowledged to have captured this condition with such an astute observation that another physician named his description for him. So this Parkinson's disease is named after a physician who captured it very eloquently years ago. And what's Parkinson's disease? Well, if we talked about this 100 years ago versus 10 years ago versus now, the slide changes, right? As we go on, we sort of learn more and more about what this disease is. And you have to kind of unpack what you know about it. So on a superficial level, we know that Parkinson's affects the brain. It's a brain condition, okay? It's a neurologic condition. And we also use the term neurodegenerative because we know that it's a neurologic condition that progresses over time, okay? And what do we know next? We know that, okay, in the brain, there's an area that produces dopamine. And we know that that area of the brain is affected more so as time goes on. There's loss of dopamine producing neurons or brain cells, okay? Well, then why? Let's unpack the next layer of that. Those dopamine producing neurons are being affected by this protein that's sort of interfering with the livelihood of these cells. There's a protein that you may have heard of, or may not, called alpha-synuclein. that misfold causes a lot of difficulty of the cell to survive. And so the cell actually dies. And that cell is known to transmit dopamine, and that's what allows fluid fast movements, okay? Disrupt dopamine, get sort of erratic movements, slower movements, and so forth. So I get this glare, so I keep doing this. Okay, so what is Parkinson's disease? I guess I can look right here. The other way of conceptualizing Parkinson's is not sort of a scientific way, but what do we see? We see a movement disorder. So it affects how a person moves, and that's like the most obvious. That's the tip of the iceberg, right? We see that ice standing out of the water. We see these movements. We may see a tremor. We may see slowness, stiffness, and so forth. And that's the obvious part of it, the not so obvious part of it, but as movement docs, we argue, we spend a lot more time on the non-motor symptoms, so the things that you may not see, but really impacts life, that's also part of it. All right, so I think I put some pictures up here, but sort of already talked to you about this a little bit. The hallmark of Parkinson's disease is what we call the dopamine deficit. So dopamine is a naturally occurring chemical that we all make, okay? And it's what we call a neurotransmitter. So it's a neurological chemical that our brain cells use to talk to each other, okay? And what we know is that dopamine signaling is very important in this really deep part of the brain that we call the substantia nigra. And there's a picture here of a person who has their head sliced open, and deep in the middle is where that area is. And they call it substantia nigra because when they do anatomical studies, actually, and you slice that part of the brain, it does appear black. So substantia nigra, or just black stuff, is what the anatomists called it. And that's a part of the brain that's really important for dopamine signaling. On the top, you see that dopamine is that little dot, and there's a neuron or a brain cell that has an arm that's projecting to another one, and those guys have to communicate to have fast fluid movements, and they heavily rely on these little particles of dopamine that sort of diffuse through that area. On the bottom image, you see that there's a reduction in that dopamine. Okay, so that's what's happening. This is a dopamine story. And that's kind of the first layer of the discussion. The second layer of the discussion is this guy here. And this is a Lewy body, this little brown blob in the middle of a neuron here. That Lewy body comes about because of misfolded alpha-synuclein protein. So basically, again, there's a protein, it misfolds, it causes a clump, the cell doesn't like it, the cell has trouble surviving, and then ultimately some of these dopamine cells die. Now you may have said, whoa, wait a minute, because I've heard of this condition called Lewy body disease or Lewy body dementia, which has many similarities and features that are overlapping to Parkinson's. And that thing, that Lewy body, is seen in Parkinson's and in Lewy body, okay? So Parkinson's, let's take a step back. This is a pretty impressive statement. Parkinson's disease is the second most common neurodegenerative disorder. Anybody know the first?
Alzheimer's?
Yeah, Alzheimer's. Yeah, this is second to Alzheimer's. Okay, 1 million individuals in the US are living with Parkinson's. And honestly, some quotes even say 1.5 million. 90,000 people in the US are diagnosed each year. That's a lot. And more than 10 million worldwide. Obviously, not everybody has access to care, so probably underrepresented. There's a nice study that actually the Parkinson Foundation puts on their website too, maybe because they subsidize it, I'm not sure, but the incidence of Parkinson's disease in North America, so really recent numbers. And what's really interesting about this study is it shows that our prior quotes, like if you look at old literature about how prevalent and how common Parkinson's is, those numbers are just very different than what last year's numbers show. So what they showed is 90,000 new Parkinson's diagnoses each year. That's what I said, but the old numbers were like 50,000. That's crazy different, right? Some 60 maybe, so then we argue like it's 1.5 times higher or more than what was previously reported. Okay, and why is that? Yeah.
Can I just make sure everyone can hear? I just heard the air click on. Can everyone in the back hear okay with that on now? Okay, so I just wanted to make sure.
Yeah, thank you. So why is that happening? As the population ages, right? This is what's going on. The primary risk factor for Parkinson's is age, okay? And so as the population ages, more people have Parkinson's, the prevalence increases. And there's this incidence that is higher in men than in women, you know about that, okay? But there's just more and more people who are going to be needing care with Parkinson's. So what do we know about the cause? I mean, there's a lot that we know, but then there's a lot that we really don't know. That is not very helpful, right? But the understanding in the world of Parkinson's is that this is a multi-hit phenomenon. It's usually not just genetics, it's usually not just the environment, it's a combination. And then there's those two variables at the bottom of age and gender, which ring true the most, okay? If we take environmental factors, more and more is being understood of which toxins are you talking about, which pesticides, how much, when in a person's life is it important. Agent Orange is now a clear risk factor for folks developing Parkinson's and Parkinsonism. We'll talk about that distinction later on. PCBs, solvents, head trauma doesn't cause necessarily Parkinson's disease, but a Parkinsonism, something that looks like Parkinson's. Genetic factors, there's a whole laundry list of genes that are associated with Parkinson's, okay? And a lot of gene panels, like if you say I want testing for Parkinson's and you test negative for the 7 most common genes, it doesn't mean that you don't have a gene that's associated to Parkinson's. It just means you don't have one of the 7, okay? We believe that about 10 to 15% of individuals have a highly heritable condition related to Parkinson's, either an autosomal dominant or an autosomal recessive. And certain ethnic groups are at higher risks than others for having sort of this increased genetic risk related to Parkinson's. But by and large, the majority of folks with Parkinson's have what we call sporadic Parkinson's, meaning they have Parkinson's, but it's not a generation above and it's not a generation below, okay? But that's not to say that there aren't cases of Parkinson's where it clearly runs in the family. So how is Parkinson's disease diagnosed? Parkinson's disease, unfortunately, is not diagnosed by a blood test or a scan, okay, or a genetic test necessarily. It really requires a doctor's visit, okay? And really any doctor can make the diagnosis as long as they know how to make the diagnosis. So you can get the diagnosis from a primary care doctor or a neurologist. A movement disorder neurologist is really usually the most specialized, but of course I'm heavily biased. And what does that evaluation mean? Like when you go to the doctor's office, what's supposed to happen? Well, they're supposed to talk to you for a long time about what your symptoms are, okay? What your motor symptoms are, what are your medications? Because sometimes medications can mimic Parkinson's or even cause what may look like Parkinson's to get rid of it to actually look better. Medical conditions that you're dealing with sometimes make people move more slowly and again mimic an underlying Parkinson's. Family history is super important. And again, lifestyle factors, because we know there are certain risk factors that maybe a Vietnam vet had, but somebody else doesn't. Neurologic examination, so after they talk to you at length, usually they're gonna wanna move your arms around and see how stiff you are and assess for something called rigidity. They're gonna wanna look at what your arms are looking like when you're at rest, and then when they're elevated, and when you're moving. Okay. Most common, we'll talk about all of these in depth a little bit more. They're gonna wanna have you do this business, right? Tap your toes, please, stomp your leg down and look for slowness of movement. And they're gonna wanna watch you walk down the hallway. I usually do it a couple times. And that's really what you should be going through among other parts of the neurologic examination. Now, Parkinson's disease is diagnosed by these 4 features. They're what we call the 4 cardinal features, okay? The paramount feature that we look for is bradykinesia. Without it, you don't have Parkinson's. Bradykinesia is slowness of movement, so that must be there. And then you need one of the other 3, just one. So that means you could have bradykinesia and rigidity, bradykinesia and shuffling of gait, bradykinesia and tremor. Some people have them all. Some people never get both of them, okay? So bradykinesia, slow movement. I wanted to give you some examples of how we try to tease this out, okay? Because a lot of people will come and tell me I'm weak. And then I'm like, all right, let's check your biceps, let's check your triceps, lift up your leg, let me push it down. But they're really strong for a few seconds at a time. So strength's actually pretty good, but they feel weak. It's their perception of how their body is moving. So then we'll sort of go through some of these. We'll look for spontaneous movement. So when a person's sort of talking with me, I hate to say it like this, but I have a half Italian background, so do you talk with your hands, right? Okay. One of my patients today said this. I was like, oh yeah, I'm half Italian too, so I'm okay. We're both okay. But do you talk with your hands? Do you just stick? What about your facial expressions? Are you smiling? Are you grimacing? Are you blinking? There's actually a slower blink rate for folks who have Parkinson's. When you do a repetitive hand movement, so like buttoning, zippering, writing, brushing teeth got hard with the electric toothbrush, so that's not repetitive anymore. Walking, speaking, swallowing. If you swallow more slowly, what happens? Saliva pools, and sometimes it comes out as drooling. You're usually not making more saliva, it's just coming out because you're not swallowing as much. Has anybody heard of this term, micrographia? No. Small penmanship. Small penmanship. And in fact, the longer the sentence, the smaller the font size. Okay, so it'll start out pretty big, font 20, and then go down to font 6 within a sentence. That's something you may look for. And again, the words that I hear from folks are not these things, but I hear this: I'm weak, I'm clumsy, and I'm uncoordinated. Tremor like they hold a squeeze ball and they just keep it in their pocket and they squeeze their hands with their hand does the tremor. Or they'll sit on their hand, because that helps too. And this tremor really likes to come out when a person walks and their arm's dangling, and it sort of likes to show itself then. But an action tremor can also be there. So you go to pick up a water bottle and it's tremoring. That's a different kind of tremor, but it may be there too. A rest tremor is not as bothersome if it goes away when you go to move something, right? But an action tremor, when the, just full water. An action tremor when you actually are shaking while you're moving, that's really bothersome, okay? And honestly, in Parkinson's, it can occur at rest, with action, and just holding something. Not moving. And it depends on what your Parkinson's looks like. But that's really when a neurologist is helpful to kind of look at this sometimes. Tremor type, help you understand it. The tremor gets even more, it is worse in your. Oh yeah, I put in some of these slides. So this is a myth, and I hear it so much that I wanted to just make sure whenever you see a black slide like this that says PD myth, this is not true, okay? This is a myth. So I don't have a tremor, so I don't have Parkinson's. Not true. Tremor is not necessary for the diagnosis of Parkinson's disease. About a third of individuals with Parkinson's do not have tremor, okay? Rigidity and stiffness. So this is one of the under-recognized features in Parkinson's by the person who has it. This is the hardest one to feel. So I will feel this by moving a person's arm while they're relaxed, maybe having them do something with the other hand while I'm moving their arm to really tease this out for them. But then I'll ask them questions like, well, what is it like when you like put your seatbelt on or put your arm in your jacket or like reach down and put your socks on? Do you feel stiffness on one side of the body more than on the other side when you're doing it? And sometimes people say, no, as much as you're feeding me this, I really don't. And that's okay, okay? This is one of the things that you may not experience, but I may see. Getting into and out of a chair or the car may be another way a person experiences stiffness. And then turning over in bed, which you know, that's a sort of an unusual thing to ask, but you find it hard. Is it awkward? You may have seen this kind of picture in different magazines and so forth, and I don't really like it because it shows that everybody has tremor who has Parkinson's and everybody has a student posture and so forth, and that's not always the case. If you learn anything about Parkinson's as a Parkinson's doc, you learn that if you've met one person with Parkinson's, you've met one person with Parkinson's. And everybody's very different. Gait dynamics. So that's one of the fourth, well, it is the fourth feature in the diagnosis. And there's so many different ways it manifests. So yes, you can be stooped. Yes, you can have a slower shuffling stride with a very small step length. Maybe one arm or two arms are not swinging as well. Freezing, I don't know if anybody's heard about freezing, but that's when you're walking along and your foot gets stuck to the ground. And it may be both of them, or it may just be one, okay? There's also these unwanted accelerations, feeling like somebody's pushing you forward all of a sudden, or you're getting a sense like you're falling backwards, okay? So many different ways that balance and position are being impacted. The tremor itself that a person may show while they're walking is not as impactful on the balance. So even though it may look like well, if we just got that better, we'd make them walk better. That's not always the case, okay? There's a couple more high-level motor symptoms that I want to talk to you about. Even though this is a 101 course, I find it's really important to learn about these symptoms. And these don't always start early on. Dystonia is an involuntary excess muscle tone causing a posture or a spasm. And those feet that you see down there represent dystonia. So you can see toes curling down, and foot inversion means, I don't know if you can see my foot, but the foot sort of scoops in and lands on the outer edge, if you will, okay? Sometimes there's like a ballerina step too, where you sort of don't land flat-footed, but more toe step. And dystonia and Parkinson's can affect the foot, it can affect the hand, it can affect the neck where you have a tilt or a turn, okay? It can even affect the face, okay, where there's facial pulling. And dystonia can occur in Parkinson's, but it can also occur in many other neurologic conditions, okay? It can affect kids, babies, all the way up, okay? So it is not specific to Parkinson's at all, but it can occur in Parkinson's. And it can be improved by medicines or by other treatments. Dyskinesia. That term represents these wiggly sort of extra movements that can impact the trunk or the head. So some people will tell me that their care partner is now all of a sudden head bobbing, just doing that. Or they're sort of like doing a shoulder elevation that's a little like rhythmic. And other people will say, okay, when I sit down, my right leg just, sorry, you guys can't see me, but my right leg sort of does like one of these. It just sort of like decides to dance on its own. And it's not a tremor kind of pattern. It has sort of a complex dimension to it. And it's almost like writhing. It's a little slow. That's a dyskinesia. I will tell you, it's important to tell your doctor, I've got a movement. Maybe show them. Maybe take a video if it doesn't happen in the office and have them review it, because not all movements are dyskinesias. Not all movements are tremors. And what happens if you say, oh, Dr. Solzko, and I have a tremor, I'll say, great, I'm going to do this to your medicine. But what if you were wrong, right? What if it was a dyskinesia? I could make you worse. So I always find it's important to make sure you're talking the same language with your doctor. It's not your job to diagnose your movement. It's your doctor's job. So make sure that when you're describing something, that you try not to use the doctor terms, because sometimes you actually do yourself a disservice and describe them in simple terms. My foot is flapping. And look, I took a video for you because it doesn't happen when I come see you. But here, take a look. This is what I mean when I say foot flapping. So I've learned when I'm keeping notes on what people say, I'll say, okay, Richard has the wiggles. And when he says the wiggles, I know it's a dyskinesia because we're talking about that same thing. And so we sort of develop this lingo, and some people will use these terms and use them correctly, and some people won't. And it's not their fault. But just be aware that that can happen. And it's important to talk the same language as your doctor. I put Michael J. Fox up there because if you've seen him on TV, he had pretty severe, he has pretty severe dyskinesias. They were more severe before than they are now. But if you saw him sort of moving about, that was what that's called, okay? So you're going through this whole process, your doctor's seeing all your symptoms, you're having this really long conversation, and then they say, and I'm gonna order an MRI. and I'm gonna do some blood work. And there's this thing called a DAT scan that you may or may not want. You guys have heard of this before? Okay, so what are they doing? What's the goal of that? Blood work is not to confirm the diagnosis of Parkinson's, right? We already talked about that, but what's the use of it? It's to look for things that would mimic Parkinson's typically, okay? So that's the importance of it. An MRI of the brain is useful to look for things that would mimic Parkinson's, okay? But not to confirm the diagnosis. And a DAT scan is a technology that we've had since 2011, FDA approved since 2011. And that is a dopamine transporter scan. So DA, dopamine T transporter scan. And it allows us to assess the dopamine levels in the brain. But it does not make the diagnosis of Parkinson's either. I sort of already told you this, but I'm really hitting it home. So my doctor ruled out Parkinson's disease with an MRI. No, they didn't. They looked for other things and wanted to make sure that you didn't have other things there that was causing a mimic condition. Got it? Good. Maybe in the future, maybe, we'll have MRIs that are more sophisticated to allow us to see the substantia nigra, the thing that I told you, that black stuff where we're losing dope. Maybe when we get like an 8 Tesla or a 10 Tesla, that's the strength of the MRI. We currently have a 3 Tesla. Maybe we'll see it. Maybe the slides will be different, but for now, myth, okay? Let me also put it this way. If you haven't had an MRI of your brain, is your doctor doing something wrong? No, it's not even necessary. Most of the time, if you have a really good clinical exam, you have a good response to medicine, and there's no what we call red flags to suggest any mimic types, we don't order them, okay? And if you're not having a surgery to help treat your Parkinson's, there's really no need for one at times, okay? So just so you know that. Also, this is an option, not necessary. So a DAT scan, again, a dopamine transporter study, is a test that, oh, that's really blurry, huh? Yeah. Is a test that looks for dopamine levels in the brain. And we use it primarily when we're trying to distinguish a dopamine deficit condition from a condition where dopamine should be normal, okay? Now, an abnormal dopamine level is not synonymous with Parkinson's disease. You guys hear that? An abnormal dopamine level is not synonymous with Parkinson's disease. If you get an abnormal DAT scan, you have an abnormal DAT scan, you have low dopamine. But it can be Parkinson's disease, MSA, CBD, PSP, LBD, and a bunch of other things, okay? So a lot of people will say, Dr. Solis-Cohen, my DAT scan's abnormal. I know I have Parkinson's already. What medicines are you gonna give me? And I'm, whoa, hold on. You just have this is abnormal, sure, but you have a dopamine deficit. Yes, about 75% of folks have Parkinson's who have an abnormal DAT scan, but I still need to put my thinking cap on, still need to evaluate you, still need to make sure that this is not one of the other alphabet soup conditions that I just sputtered out, okay? So DAT scan, I think this is super important, not specific to Parkinson's disease, can be abnormal in other conditions, but very useful depending on the question we're trying to ask, okay? And it does use a small amount of radioactive tracer. So it's safe, but it requires an IV. You have to go to an imaging center and wait there for a long time. And then you get these beautiful pictures where this is normal dopamine, that's low, it's sort of that orange center is attenuated. I like using the word Parkinsonism, and I like distinguishing it from Parkinson's disease. Parkinsonism is a descriptive term. It does not imply a diagnosis. Parkinsonism is slowness plus stiffness, tremor, postural instability, or walking imbalance, okay? So it's just like if I wanted to describe all those things without saying all those things, I would say Parkinsonism, okay? Parkinsonism is an umbrella under which there are many diseases, okay? And they're different from each other, and this may be a little blurry and small too. But there's the typical Parkinson's disease, and then there's all these other things that you see, okay? And only by understanding a person's response to medicine, looking for other certain features that may go along with those atypical Parkinsonism, sometimes looking at an MRI to see if there's a mimic condition here, are we able to sort of sort all these things out? And if you've heard your doctor use the term Parkinsonism rather than Parkinson's disease, it may be because there are certain features that don't fit quite right, okay? And it's not wrong to use the term Parkinsonism versus Parkinson's disease, but it just means that there's something a little bit different about it. We don't usually have a whole different set of medicines for that. We usually use the same medicines, but we'll expect maybe a different set of symptoms. Does that make sense? Sort of? Are you guys doing okay so far? Yes, question.
When you say it's the same thing, my husband's a neurologist said, when we were discussing it, when I said, but it's not Parkinson's, she said it's the same thing. She called it Parkinsonism. Would you say it's the same thing? Kind of, because it's under that umbrella.
So Parkinson's disease is Parkinsonism. PSP is Parkinsonism. They all are Parkinsonism.
Anything under that umbrella.
They're under that umbrella. So I guess it's yes, but Parkinson's disease is different than the atypical varieties, if that makes sense. So it gets a little like play on words kind of situation, right? I know.
It's confusing.
I know.
Okay.
We're not doing too bad on time. That's good. You know, the big story is how your body moves, right? The big story is about the tremor that you see. The big story is the difficulties with walking or this abnormal movement or that. And the hard thing is what it feels like inside. You know, a lot of times it's easy to address the outward symptoms and just not bring up any of these guys. We call these the non-motor symptoms. And it's because of this long list of things that a lot of the movement disorder doctors wind up feeling like primary care doctors. Because we're talking about all these different things that affect the body. So we'll sort of walk through them a little bit. Some of them precede the motor symptoms by decades. So then people tell me, well, how do you know when it started? We don't. We just call the diagnosis based on the onset of your motor symptoms. But yes, this process has been trickling along probably for decades before. And what are some of the earlier signs? Loss of sense of smell, or our fancy words, anosmia, hyposmia, okay? Loss of sense of smell. It's not that you can't smell, but it's just things don't smell as strongly, if you will. Okay. Another motor symptom that can technically proceed by decades is constipation. And there's some case reports that say constipation can start in high school for folks who got Parkinson's later on. Yeah. And another one is this third one, actually. I would skip over urination for a second, but REM sleep behavior disorder, active dreaming, vivid dreaming. A bear is chasing me. Get that bear away from me. I'm punching in the middle of the night. I'm screaming. Sometimes people actually grab onto their care partners and may hurt them unintentionally because they think they're trying to protect themselves from this bear. That is very real in the middle of their REM sleep. REM sleep is a normal part of sleep where we all have vivid dreams, quite honestly. You hopefully don't all remember them. But in REM sleep, your body is actually supposed to be in a partially paralyzed state where you don't move. And the disordered portion of it is you move. And that's super dangerous because you're just trying to protect yourself in your sleep. You're not trying to hurt anybody, but sometimes people do get hurt. And so if this is going on, I get very real with folks in the clinic. And I had one today too. If you're hurting the person who's in bed with you, no. There are some options that we have. You have medicines. They can sleep in a different bed. Did you ever hear of a bed barrier? You can do a lot of things. But it is a real reason that people can get hurt. And a lot of people don't like talking about it because it's, behind closed doors. It's very important to talk about. Okay? Sleep, so really anosmia, constipation, and REM sleep behavior disorder are 3 early non-motor symptoms. Those are the classic 3 that we may ask about for a person who has a tremor to see if they have this risk for Parkinson's versus another kind of condition. There's a whole lot of other things. We'll go through those more quickly. Urinary frequency and urgency, the need to sort of go to the bathroom quickly because you get an urge and you get a minute and that's it. Okay, or you're waking up at nighttime 5 times to go to the restroom. And that's another thing to talk to your doctor about options, what medications could be appropriate, what other sort of options you have that are not medications, okay? That could be helpful, yes.
Would the neurologist want to hear about all these symptoms, or should we be telling them PCP?
Yeah, so it's a really good question. And it depends on what's going on and how long you got. Because you imagine if you're going to be talking about all these things, you're never leaving, right? You're going to be there. So it depends on the style of the neurologist and what they're willing to take on, quite honestly. My personal approach is if it's on this list and I feel comfortable treating it, I will. But it's also, I've got to make sure I can see all of my patients of the day. So I may say, Susie, we're going to talk about, these 2 non-motor symptoms, and next time we'll catch up on the next 3. You know what I mean? But it's a little bit of back and forth there. The primary care should always be part of all of these. Okay, they may not always understand what the connection is to Parkinson's, so that's why the neurologist is important. They may not know that you're sweating, that you're getting at the end of a shocker medication occur to them. The bottom of the list, pain, is something that we used to say in the book, and myself, pain, we're wrong. It does. Pain ratings are higher in individuals who have Parkinson's than folks who don't. And we can't explain it. We don't have a good answer for why that happens. But it's important that we educate people so that they understand what's part of their Parkinson's and what's not. Okay? And so I think, yes, the answer should be, you should always be talking with your neurologist about it. We are going to have to sort of triage what you're bringing to the table, right? For sure. It's a lot. All right, restless legs. You guys ever heard of restless legs? Feeling like you've got creepy crawlies or sort of zaps or jolts in the legs. It goes away when you walk. When you try to go back to bed or have a long plane flight or something, it'll come back. Okay. Cognitive changes. So Parkinson's can cause dementia. Okay, it can cause dementia. Before causing dementia, okay, it can cause more subtle changes, which is typically what I hear, though I do see the latter too. But the more subtle changes fall under a category called mild cognitive impairment. And usually the complaint is, I have difficulty processing when people are talking fast, or I'm in the middle of writing an email, the phone rings, and I just have trouble getting back in. or I have trouble paying attention to the news because I just feel like it's just too fast, it's just too much. I can't keep pace with it. It's not so much I can't remember what you told me an hour ago, okay? It's not so much that, but it's this speed of processing, this attention sort of driven thing that's hard. Hallucinations, that's another thing people don't like to talk about because it's very scary, very scary. Hallucinations, or even another word called illusions, if you've heard that. You know, I think that the visual changes in Parkinson's, there's different layers. So there can be like a black spot. And you look over, and that's something? No, there's nothing. Okay, I'm fine. Or there can be spiders. Oh, they're not there. Okay, I'm fine. Or there can be snakes. I'm still looking at the snake. It's still there. Okay, the snake's coming toward me. Okay, now I'm getting a newspaper, right? So there's layers of reacting to some of these visual things that happen. Most often for hallucinations, the good thing is they're not all threatening. So there's a lot of medications for this that have really scary ads, if you've seen the snakes and the things. Usually it's not as scary as that. It's more like small children, small animals that are not threatening. But the fact of seeing something and looking and you're like, do you see that? Because I'm still seeing it and I'm still looking, that's the problem. And what our job is as neurologists, and usually this one falls on the neurologist, just so you know, is that we have to determine the level of this symptom being bothersome and interfering with a person to take their medicines, get good cares, and determine what safety is, you know, if they're driving, if they're at home alone, and that sort of thing, okay? But hallucinations can be treated. And so it's very important to bring these up because it can be treated. Yes.
Are they primarily visual hallucinations or the auditory?
Oh, such a good question. So all of them. All of them. Visual, auditory, less so, and then tactile hallucinations also, but less so. Those last two, the feel ones and the hearing ones, much less so. It's usually visual. Mood changes. I think this one is, for me, the hardest. Anxiety, depression, apathy, impulsivity. It's the hardest as the treating doc because we fall short all the time. We fall short in adequately addressing this. And there's a lot of stigma associated with having a mental health issue, right? And we're getting better at it. That's true, but it's still really hard. And it's hard to convey to a person. I'm gonna say this from the doc side of it, okay? It's hard to convey to a person, hey, I know that you're not feeling this way because woe is me, I have this disease. But what's going on is just like you have that dopamine deficit, right? That problem with that neurotransmitter. Hey, you also have a problem with serotonin, which is the feel-good hormone, okay? That one's low too. And so the fact that you don't feel good, you feel anxious, you feel depressed, is not just because of this dopamine story over here, it's also this serotonin is a big problem too. And so what we try to do is explain and educate to people that it's not usually the, oh, woe is me, I just feel so low because I have this condition. It's not that. It's that your brain is actually causing you to feel that way. And maybe it is worth another medicine. You know, a lot of people say, well, listen, you've given me carbidopa, levodopa, rasagiline, amantadine, and now you want to give me a mood medicine too? You got to be kidding me, right? And so we back off, right? But maybe that one's actually way more important than some of their other motor symptom medicines, quite honestly. You know, there's this concept, and I don't know what's time is it. We'll go through this list and then take a break. Yeah, there's this concept called pseudo progression. Pseudo progression. So your Parkinson's is not motor-wise progressing. You look like you're progressing, but it's a pseudo phenomenon. So what made you look like you're progressing that was not actually the Parkinson's? Undertreated depression. Moving slow is not always bradykinesia from Parkinson's. Moving slow is sometimes depression. Apathy. I just recently listened to a really good continuing education thing on apathy and Parkinson's. I want to share one little pearl from that. And that was folks who have apathy, which is sort of like this lack of motivation to do things, they're not usually bothered by it. They're like happy to sit there, you know, and they don't really, but their spouse really gets bothered by it. And, you know, we sort of know that in the Parkinson's world. This is a big problem, apathy, and our antidepressants don't usually help with apathy that much, quite honestly. But here's the pearl that I learned recently was apathy responds to a schedule. People are apathetic because they don't have motivation to make a schedule. But give that apathetic person a schedule. Tell them they're following this routine, and apparently there's a better chance. I haven't tried this yet, but I think it's a good sort of like, let's see if we can help somebody with a problem that is otherwise really hard to treat. So give them a schedule. At 9, you're, you know, going on a walk with me and the dog. At 10, you know, I'm going to give you this project, you're going to do that, right? Anyway, try it on for size, get back to me. Orthostatic hypotension. Okay, so orthostatic, position change, hypotension, low blood pressure. Low blood pressure that happens when you stand up, okay? Most people don't know about this. And in the clinic, we do a really good job of hammering this one down because this one we can really treat. We can treat this one. If you stand up and feel dizzy, and even worse, you pass out or fall down and hurt yourself, we can help you with medicines. And we can teach you about this so you hydrate. Okay, like everybody's doing, not drinking their water bottles. So, I mean, me included, but this is very chronic. This, you know, so this is really important. Drinking, hydration. There's a bigger fluctuation in blood pressure in an individual who has Parkinson's when they stand up compared to the individual who doesn't, and it can get worse with age, okay? Honestly, there's some people who, before their diagnosis of Parkinson's, have a diagnosis of high blood pressure, right? Very common condition. They're on amlodipine and lisinopril. Years into the Parkinson's, their primary doctor's like taking those off. Like, what happened? This happened. Your blood pressure tends to be swinging when you stand up, so you can actually get rid of some of your medicines. So if you're struggling with low blood pressures, or if you feel dizzy when you stand up, get a cuff. Take your blood pressure not when you're seated, but when you're standing. See what that number is. Fatigue, just higher rates of fatigue in Parkinson's, but there are treatments for it. Also higher rate of sleep apnea in Parkinson's. That can cause daytime fatigue. Some of our medicines cause fatigue too. Having untreated depression can cause fatigue. Drooling. Also, set of medicines that are independently available for treating of drooling. Sexual dysfunction on many levels is impacted. Skin changes, increased rate of melanoma. Seborrhea, which is sort of like a dysfunction of the sweat glands, usually causing these sort of like light brown patches on the skin. It almost looks like you could pick it off kind of a thing. There's treatments for those. But really important, living in Colorado, to get skin checks for folks with Parkinson's. I would be lying if I said that in my clinic, I don't see melanoma. I do. There's just a higher rate. So make sure you get checked out. Shortness of breath. Not as common, but occurs. People have to go to the cardiologist and the pulmonologist and go through all the workup, and despite all of that, sometimes the breathing rhythm is impacted. Sweating. We didn't used to understand this one either, but as a part of when a person's medicines are wearing off, there can be this wave of sweating that happens as a manifestation of those meds running out. And then pain we talked about. Anybody? Yeah.
Would feeling cold sort of fall under that?
Oh, yeah, that's a really good one. I didn't put it on there. But yeah, thermal dysregulation. So like feeling cold or feeling hot and not being able to regulate your body's temperature. Yes. Yes. I'm sure I didn't get them all. Okay, I think, yeah, okay, there's just this last one. Average individual has 8 different non-motor symptoms from that list. To add. So let's do it. So we talked about like all the things that can come about because of Parkinson's. And now we're gonna start to talk about how do we deal with those things. Okay, that's gonna be the second part. Usually a talk about how to deal with those things is like multiple days. It takes hours to talk about all the medicines in Parkinson's. So I do not have a slide on all the medicines in Parkinson's because I don't. But I have one about the most common one. Okay, so I'm shortchanging this part, but I'm going to talk about it more in generalities than individual medication names on purpose. When we talk about Parkinson's disease treatment options, it's really important to understand what the goal of the medicine is. And when we talk about medicines in general, there's different levels of impacting a medical condition. And I'm just going to focus on 2. So one impact is if you actually modify the disease, slow the progression, or halt the progression. That's what we call a disease modifying therapy. Okay. Can you slow or revert Parkinson's? There is no FDA approved disease modifying therapy in Parkinson's. But guess what? You can do better than that, because exercise has been shown to slow disease progression. And guess what? Remember those non-motor symptoms we talked about in the beginning? Having constipation and hyposmia or anosmia or REM sleep behavior disorder. Folks who were at risk and studied, okay, so folks at risk with those features who exercised heavily versus couch potatoes. The couch potatoes developed Parkinson's sooner than the folks who were heavy exercisers. Exercise does delay motor symptom onset, okay? And exercise helps reduce the severity of disease progression more than any FDA medicine. So anything that you need to do, well, legal things, but anything that you need to do, so like I've got to be careful with my words, I'm very bad at that, but anything that you need to do that is legal, you should optimize your ability to exercise, right? Like I see people like, oh, it's one knee, and I can't exercise. No, go get that knee fixed. Go get that knee. I need you working out. You know, or I'm so apathetic, I can't. No, this is horrible. You need to exercise. It is very important because my drugs, these medicines that I can give you, are not as important as you exercising. And the bad social experiment that happened with COVID when all the gyms shut down, Guess who saw it firsthand? Dr. Souls Cohen. My Parkinson's got so much worse. May 2020. Because guess what? My gym closed down. Seriously, it was bad. So I cannot tell you enough times, like I would just spend 2 hours talking to you about how important this is and making sure that if you are not exercising because you're apathetic or because you're depressed or because you have a bum knee or because you're dizzy when you stand up or because you sweat so much because of your Parkinson's, it doesn't matter. Like all those things need to be taken care of, okay? And then if you can't exercise because you can't walk, guess what? You can. You can lay on the floor and do some Pilates, or you can cycle a bicycle. And it's like tough love here, but it's tough love because we know how important it is. Okay? I'll get into that more later because that's really my soapbox. But disease-modifying therapies, they're studying a lot. And you'll read in the Parkinson's news updates about this disease-modifying therapy, that disease-modifying therapy that are in phase 2 and phase 3. And we're really exciting because we know and we're hopeful that this slide will be different soon, okay? But right now, it's your exercise that we need, okay? Symptomatic management, that's what we have for you with medicines. We manage symptoms, okay? It's like a Band-Aid, that's all it is. It's medicines to help reduce the severity of a tremor, the degree of stiffness, the degree of slowness, for walking, maybe less effective, quite honestly, okay? But we have symptomatic management. Oh yeah, here we go. See, exercise, a whole slide. So exercise, all of the things here. So what do you get out of it? Preventing or slowing progression. Studies have linked exercise to reduce risk of Parkinson's and slower progression. Managing symptoms helps motor and non-motor symptoms. Strength, balance, and then all those non-motor symptoms. Guess what? Mood usually gets better when you exercise, right? Constipation, right? Sleep. Avoiding isolation. So a lot of new data in the world of Parkinson's and quality of life ratings and who does better and why do they do better and who thinks they're doing better with their life, even though their motor scores are the same as their, next door neighbor. The folks who are socially plugged in do better. The folks who make sure that on their calendar they have social outings, and even better, social outings for exercise, awesome, okay? How much exercise should I do? This is sort of like not, it's not an easy answer because there's a lot of studies about this, quite honestly. But what we say in general, and usually it's movement disorder docs say like the same number. It's 150 minutes a week. Okay, so that's 5 30-minute sessions. Right? You can do it because you have to, because I said so. I've even written, this on a prescription now too, right? Best exercise. We don't care. We don't care. There's a lot of really interesting studies about Tai Chi versus high intensity interval training versus, I saw one recently about cross-country skiing. They're all great. They're all great, but I don't think the data is rigorous enough for me to say Tai Chi for all. Okay, do what you like and make sure you can continue it because you're doing this. You're not stopping, right? Like this potential benefit that you can do for your condition is never going to go away. Like you need to commit to this. Okay, so find something you like. Find something you like that you could even do with a friend. That's golden. Oh, this is super small, but I find that this is a website that everybody should know about, okay? So rehabilitative therapy. By virtue of having Parkinson's, you have the opportunity to go to physical therapy, occupational therapy, speech therapy, okay? Visit with a social worker, okay? Go to cognitive behavioral therapist, all kinds of therapy you have the opportunity to do. Some are covered by insurance and some are not. Okay. Lee Silverman voice treatment or Lee Silverman voice therapy you may hear of as LSVT, big and loud. Okay. Our therapy is directed towards people who have Parkinson's. And in major academic institutions, like in the university, for example, they're all right there for you. It's all put together. I work in Littleton, where things are more hodgepodge. And people have to kind of find the people that they like. So I'm a big proponent of this website, LSVT Global. If you could actually see that, there is a link that says find an LSVT clinician, and you can type in your zip code and find a person that's nearby you. But there are many really talented therapists that we have in this area who can help with these therapies. Why should I go for physical therapy, occupational, and speech therapy? There are exercises that will help broaden the movements, okay? Speak louder, fine motor work. It's hard though. It's a lot of work. And sometimes if you don't practice those exercises, you speak quietly again, right? But physical therapy is very important, especially when there's balance issues, because we need to keep you active and we need to keep you exercising. And if you're not able to, you're not doing as well as you could be, right? So anyway, my soapbox, I'm sorry. How do Parkinson's medicines work? So if we put sort of the exercise and the therapies aside, there are medicines, and how do they work? So Parkinson's symptoms are caused by a lack of dopamine in the brain. We already talked about that. There are what we call dopaminergic medications, or dopamine boosting or mimicking medications, if you will, to help increase that dopamine level in the brain, or even better, to help trick the brain into thinking there's more dopamine there than there is, or to help the brain not break down the dopamine as much, or just to help with those dopamine circuits working faster. The goal of those medicines, and there is a list. Those medicines help reduce stiffness, improve speed coordination, may improve tremor, okay? And when you say like, okay, so I'm taking this medicine, you expect what, like tremor to be reduced for me or rigidity to be reduced for me? I'm like, actually, the benefit from the medicine is very individualistic. I'll give the same medicine to a person with Parkinson's and their tremor may get better, but the next person, they may still have tremor and their stiffness may get better. So again, if you've met one person with Parkinson's, you've met one person with Parkinson's, because the response to medicine can be very different. Okay, so I just wanted to do one medicine, and this is our gold standard medicine, carbidopa-levodopa. And it's easy to think of it as like the dopamine supplement, if you will. Carbidopa-levodopa, you generally see together. It's been the gold standard treatment for over 50 years, I think like 1968. Yeah. And levodopa, so that second portion, is actually just an amino acid, and that's a protein building block, okay? So it's pretty natural, if you will. Your body takes up that levodopa. So pill goes to your stomach, small intestine, into your blood, up to your brain. And your brain recognizes levodopa because there's an enzyme in your brain that latches on to levodopa and just makes dopamine, okay? And the dopamine allows that circuit to be replenished, more dopamine there, may move quicker, more fluid, less tremor, okay? Again, this thing that I said, there's an individualistic profile of motor symptom improvement, right? Person one has a better response with tremor, person two, you know, everybody kind of usually that slowness gets better, somebody's stiffness, but it's not all the same. So when people come back and see me after they've taken this medicine and started it a couple of weeks before, they'll say, so what got better? And I don't mean that to be joking, like, I'm interested. What of your symptoms got better and what didn't? Because we need to keep working, okay? So it's important to really think about that for oneself. What got better? What didn't? And then potentially what side effects am I experiencing? So the side effects from carbidopa, levodopa are very small font at the bottom, I think, right? Sorry, I really need to blow up this font next time. But the whole laundry list of side effects, I'll go through it in a second here, they're minimized by the carbidopa, okay? So the reason those two are together is because if you took levodopa, you'd probably be vomiting, flushing, feeling very much unwell. And it took a little bit, back when this was first FDA approved, well, it was before FDA, but back when it was first used, to understand that this had to be given in conjunction with carbidopa so that actually a person can tolerate it. And carbidopa helps mitigate those side effects. But still they can occur. And most commonly I hear of nausea, less commonly vomiting, very rarely vomiting, lightheadedness. But as you know, lightheadedness can occur in Parkinson's, right? So then we're like, well, was it there before? Did it make it worse? What's going on? Is it the meds? Is it the Parkinson's? Low blood pressure, again, a Parkinson's thing too. Confusion, hallucination, guess what? Also a Parkinson thing too, right? And then dyskinesia, which I sort of warned you about, those wiggly extra movements. Okay, so those are common side effects to see with carbidopa, levodopa. More often than not, people do well and don't have side effects, more often than not. And if there are side effects, more often than not, we can sort of work our way around those side effects. But the beautiful thing about this medicine is this medicine is generic, it's cheap, it's well stocked, okay? And so it's not usually a hardship financially. Well, not usually, it is not a hardship financially. Because this medicine is so good and so effective, there are many iterations of it. So there's a controlled release, there's a Rytari, there's an inhaled levodopa, there's a disintegrating one under the tongue. You can even get carbidopa, levodopa and feed it through a feeding tube, and it's called Duopa. And we're waiting for a subcutaneous version, so a pump under the skin. It's kind of like an insulin pump. Doesn't require any surgery beforehand, to give this continuously, 24 hours. So we're waiting for, hopefully, soon. Carbidopa, levodopa is generally a good place to start as a medicine in Parkinson's, okay? But it's not the only place to start. And there's other options if it doesn't work, okay? But it's something that you'll sort of hear a lot about. And then if you don't hear carbidopa, levodopa, you'll hear Sinemet. You guys heard that term, Sinemet? You know what it means? Sin, without, emet, emesis, vomiting. So when they first got the combo, they were so thrilled that they called it without vomiting. Okay, so you won't forget that one. Sin, emet. Maximizing your benefits of your medicines. So just like you pointed out, going to your doctor's office, sometimes like it doesn't feel like you're in charge of the visit, right? You're like, I've got a time limit, I've got this list, and they're just like, take another half tab and I'll see you next time. Sometimes it feels like that, right? So be very prepared when you go to the doctor. This is not like going because you have a hang-in. This is like a multi-system condition that you're trying to get a lot accomplished in all of these visits. And I get that. On the other side, I get that. make sure that you have a list of questions. Make sure that you thought about what's the priority of those list of questions in case you don't get to the home, right? Make sure that you're keeping track of when you're actually taking your medicines versus when your doctor is telling you to take your medicines, right? Because they may say, okay, take 1 tab 3 times a day, and you may say, that's fine, but this is my body, and I'm only ready for a half a tab right now, right? The problem is, if you don't tell them that you did that, and there's not an honest relationship there, guess what? They're gonna take the next step, and they didn't know what you were doing, right? So just make sure that you're really telling when you're taking it, how often you're missing a dose, because everybody's human, right? What happens when you miss a dose? What happens if, oh, I messed up and I took 2, and I realized after the fact. For me, that's golden information. Knowing what happens with folks who miss a dose or take an extra dose by accident. That's really important to me. And it says take doses on time. It's a nice thought, but it's hard to do all the time, right? So what happens to you when you take your doses on time versus when you're late? We want to know that information. And then there was a comment during the break about meals and medications, and usually we spend a whole bunch of time on that. So I'll give you a little rundown on that too. Not all medicines have a meal interaction relationship in Parkinson's, just so you know. It's medicine dependent. Carbidopa-levodopa does. Okay. So because carbidopa-levodopa is a breakdown of protein, it's an amino acid, it wants to get absorbed by the same receptor in the small intestine as protein. So if you have a hamburger and you take carbidopa-levodopa, they're vying for the same receptor in the small intestine. Okay, that's the science behind it. Okay, so if you want to get all your carbidopa-levodopa absorbed, you're going to do it without protein competing, right? So that's where this principle comes in. Don't take carbidopa-levodopa unless it's 30 minutes before a meal or an hour after a meal, okay? That allows you to get as much of the medicine absorbed as you're going to get, because it's not competing with protein. It's hard to say, well, I'm just gonna eat carbs or I'm just gonna eat fat, because all of these things are intertwined, right? So usually it's meal or no meal. But then there's reality, because picture yourself taking medications 5 times a day. Like, the question is, what do I eat, right? You don't, no, you have to eat. But the real answer is, yes, even though protein combines with carbidopa-levodopa, if you only had 70% of it absorbed, it still wouldn't work, right? Just a little less so. So there are strategies that you should bring to your doctors on an individual basis. Like the question of, does that apply to me? Do I have to take my meds without my meals? Or does that not apply to me? And I honestly have different answers for different folks. Folks who wear off, and we'll talk about wearing off in a little bit, so don't get nervous, I'll go there. Folks who wear off or really feel like their medicines only last for a short period of time, they have to be more regimented about no protein with their meds. Versus other folks who say, like, I don't know what that wearing off means, that never happens to me. It won't really affect them. So even though the medical textbook says, absolutely, make sure that your meds are 30 minutes before a meal or an hour after a meal. That's like a one-fits-all answer, right? And you know what happens in Parkinson's, that doesn't work. That never works. So does that help? Kind of? Okay. Yes.
What about iron? I think I read something about iron.
Yeah, so it's better not to take it with iron, but the data is sort of like a little bit less strong. So the concept of like supplements with carbidopa-levodopa that should be like an individualistic answer with your doctor too. Okay, sorry, but I'm gonna push back on that one.
So some of the places said 2 hours, kind of 2 hours before.
I know, I was trying not to say every anecdote, but I had somebody yesterday who was like an hour before and 2 hours after, and that's like a West Coast thing apparently, so, it really depends on, you know, who you get this information from, what the time frame is, but that's not possible. You know, like, maybe it is for you, but it's not for me.
Cut down on snacking.
Doesn't, but it's, you know, you need nutrition too. What are you supposed to do? So, you gotta sort of find something that works and, again, sort of triage, I've gotta stay alive with food. So, again, that should be really something that's discussed on a personal level with your physician to understand how important that recommendation is, what wiggle room you have, to come up with something that makes sense.
So if you take your medicine, and you're real careful about your medicine 3 times a day, if you change it to half an hour off for light or early, is that any big difference? Not regularly, but something's coming up, you've got just, is there a time amount?
Oh, that's a good question. It really depends on what stage of the condition you're in. Okay, if you're gonna have an adverse symptom from doing that, so like if there's gonna be a side effect for taking your meds too early. So I would have to answer that on a, like an individualistic,
It's better later than earlier if you're gonna do
Basis.
something.
not always.
Not always, okay.
Yeah.
Don't do it.
So that's a talk to your doctor directly, because it can go both ways in how I would answer that question, depending on what's going on. And I don't want to sway you in the wrong direction. Yes.
Do you determine the amount of medication you start on? Like when I went up half a tab for, you know, and then worked up. But how do you know it's 1 tablet for 3 times a day? How do you know that that's enough dopamine or it's not enough?
Just watch what your symptoms are doing. So we watch what you look like, how you move, to determine if you're on enough medicine or not. Okay,
Can you be on too much?
yeah, absolutely.
How do you know?
Well, you're looking for side effects related to those medicines. So if you were to have some of the side effects that we listed here, then that would be too much for you, potentially. If you're there having all the wiggles from the dyskinesia, then that's at a higher level. And if all your Parkinson symptoms, motor symptoms that interfere with quality of life are treated and your physician is still going up, then you're overtreated. Again, these are very individualistic questions. I usually ask folks for feedback as we're going up, and half a tablet 3 times a day of carbidopa levodopa is a beginner dose. Okay, usually we wait a week and then go up to a tablet 3 times a day. That's beginner dosing. Usually I ask for feedback on, do you think you're better on this dose versus that dose? Are you better on 2 tabs 3 times a day than 1 tab 2 times a day? Because if you're not convinced of it, I've got to check you out very carefully. And if I'm not convinced of it, then what's the point in more medicine, right? Just sort of simple. So it's sort of like a 2-pronged approach. I'd like to see benefit. I'd like to hear that you're convinced of it and not questioning it, to answer that question too.
So when you take these medicines like that, do they delay the progression of disease because now you're getting a lot of the dopamine?
Nope,
It's just treat symptoms.
just treat symptoms. The only thing that you can do for this one is exercise, which is why it's way more important that this is the priority of discussion than a half a tablet versus 1 tablet. Because this is what's going to change. Symptom treatment is just like a Band-Aid. So this is a myth, okay? a myth, a myth, a myth. Parkinson's medications stop working after 5 years, so I should delay starting treatment. I don't know if anybody's heard this. That's good that you guys are shaking your head. We're winning. Tremors. But this is a myth, and Parkinson's medicines work for decades, actually. What make people think that they stop working is the progression of the disease. Okay? And I make an analogy to folks about Parkinson's disease and the dopamine deficit like a bucket. Okay? So in the beginning of the condition where the dopamine deficit is small, you got a small little bucket, and I get to give you dopamine medicine and fill up that bucket, and my job is very easy. Many people are just very thrilled with what happens, not all, but many, okay? Over time, that bucket gets bigger. Gotta give more medicine, right? Now, when we give more medicine, what happens? The potential for side effects goes up, right? My job gets harder. People are less thrilled, you know? Then it looks this big bucket. And I have trouble filling that with dopamine medicines because of all the side effects that people are having. So then I have to like back off, and I can only give this much, and then it feels like they're not working anymore because I can't fill the bucket anymore. Does that make sense? And so it's not that after 5 years they stop working, it's just your bucket got big. And you couldn't tolerate all the medicines that I'm giving. So that's what's going on here. Okay, but I'm glad, because if we were here, I don't know, 10 or 15 years ago, everybody would be like, yeah, that's right. No, we're not gonna use this medicine. So that's good. Motor fluctuations, on, off periods. Okay, so the honest take on offs is not everybody has them. And some people really get confused when I start talking about this. I don't know what you're talking about, on, off. Do you mean that I just take my medicines and now I'm not taking my medicines? People get very confused. And what I'm trying to say is that there is different versions of a person's motor state related to medicine. And on is when you take your medicine and there's a period after the medicine where your slowness, stiffness, tremor, walking, maybe one of those, or two of those, or three of those, get better. So that's when you're on medicine and your Parkinson's symptoms get better, okay? The off is there's a period potentially after you take that medicine and have the on period that there's reemergence of those symptoms, the return of slowness, stiffness, and tremor. That's off.
Talking about in the same day or over a period of time?
Good question. Same day. Most folks who are in the earlier stages of Parkinson's don't experience this. Okay? Motor fluctuations don't typically happen early on. And so it's really honestly less applicable to our discussions today. But because you guys are here learning about it, it's important to bring this concept up. In the beginning, when people start Parkinson's medicine, there's often this thing of, well, you know, if I'm late on my second dose, or hey, if I forgot that third dose, and I don't suffer because of it, this medicine's not working. Even though I had benefit when I started it, I'm late on my meds, it's not working, and then there's this sort of doubt about what's going on, and is this medicine helping me? And that's just because you're not having wear and off. You're not having motor fluctuations. There's no on and off of you. That dopamine was enough of a good thing for your dopamine system that who knows how long it's gonna last. Maybe a whole day, okay? But still we recommend 3 times a day dosing, okay? Just so you know, don't shortchange yourself. But motor fluctuations and off periods happen increasingly as the disease progresses. Okay, so as the years go on, there's a higher potential for understanding what this means. understanding I can't be late on my medicines. Because if I am late, my tremor really reminds me it's there. Okay? And then sometimes these motor fluctuations are predictable, like they happen every 3 hours, or sometimes they can be unpredictable and really interfere with the person's functioning. I'm just realizing what time it is. It's 6 o'clock, so if anybody has a important dinner date to go to, feel free. I can keep going, I can answer questions. This is all about you guys. What would you like me to do? Keep going.
But people leave things, right? People leave things. Yeah, I'll come to the next.
I'll be very offended when you leave this. Not at all. Okay, so early Parkinson's disease, graphs. Follow me on this one, okay? So on the y-axis over here, there's 3 motor states, 3 different versions of an individual. Off, their tremors there, they're walking slow or they're stiffer. On, they're walking nice or they're feeling better, their medicines are working. On with dyskinesia, they're still walking faster, but this time they're walking with dyskinesias, okay? 3 different motor function states, same day, same person. Take carbidopa, levodopa, okay? So they wake up in the morning, maybe they're a little off here. They take carbidopa, levodopa, their dopamine levels rise. Then they fall. They take their next dose, they rise. And then they fall, they take their next dose, they rise, and they fall. But look what happened. This person has early Parkinson's disease, and despite the rise and the fall of their dopamine levels, they remain in the good on motor state. And that's generally where people are in the first few years. So despite taking their medicine, they're still pretty good. They're in the good on motor state. So they're scratching their head, what does she mean by on and off? So I don't have any, I'm on. I never feel these guys. Watch what happens. As the disease progresses, same day, same person, they wake up in the morning, now they're off. Now they wake up with that reminder of their slowness. They take their medicine. Okay, now I'm on, I'm feeling good, I'm feeling good. Oh no, I'm feeling good, but now I have the dyskinesia there. Okay, as time goes on, that relaxes down, they're back to feeling good. Then they're off. Now I'm shaking again. My tremor's back. Take my next dose, same cycle. Feel good for a little bit, then on with dyskinesia, then I feel good a little bit, then the tremor comes back. That's the roller coaster. Okay?
Can you just repeat what the dyskinesia is?
The dyskinesia is that wiggly extra movement. And
So
it,
that's not good, and the off is not good.
correct.
So you're going from good to not good, and then you go back to not good.
Yeah, and you catch the good only when you're in this margin here. Can you imagine what that feels like?
No, no.
Yeah. And it's not to say that you will get it if you have Parkinson's, okay? But it's what we're talking about when we say there's motor fluctuations, because you're fluctuating different motor states. And this is very dramatic. I'm being dramatic here on purpose, okay? Some people will just stay in the top 2. Some people will just stay in the bottom 2, okay? They may not get all 3, okay? And it may not happen for every dose, too, okay? But I think it's an interesting thing to think about because it helps you understand the fact that in one day, the same person may look very different depending on if they're in front of the doctor or if they're, 2 hours later, right? So one of the common things that I do is like, okay, when did you take your last dose? Right? So I'm going to examine them. While I'm doing that, I always ask, or try, I'm pretty good hit rate, but when did you take your last meds? Because that's going to impact what I do for them. I want to know where on this curve they are, right? Moving target.
Should we schedule our pills a certain time according to the doctor's appointment?
You should take your pills when you're supposed to take your pills, unless your doctor tells you differently on purpose. There are some times where I tell people, hold pills for 24 or 12 hours or whatever, because I want to see what you look like here. Or there may be a case where I say, okay, next time I want to see you here, so you'll take your med like an hour and a half before you see me. But that's few and far between. Most of the time I take people as they come. And I just want to know, okay, what time was it that you last dosed? Okay.
Excuse me, as the disease progresses,
Yeah.
is there a time when he just said he'd like to see it even out, he doesn't like the ups and downs?
Yeah.
Is there a time that it will even out, or as the disease progresses, is it going to be the ups and downs?
As the disease progresses, typically there are the ups and downs. You have to rely on medicines to help minimize the swings.
Okay.
So a smoother swing, okay, help flatten out the peak, okay? That subcutaneous levodopa that I was mentioning that we're waiting for is going to offer you potentially a straight line between those two bars, okay? So I don't think we're able to change the disease trajectory, but I think that what we're shooting for is like, can we get our therapy to be between those two lines? Okay, and so an extended release medicine, carbidopa, levodopa, or other things can help sort of like make this wiggle line potentially not go so above or so below the lines, if that makes sense. You guys are following. This is really hard stuff to totally follow.
They frequently give you the long acting versus just the regular one?
Yeah. Yeah, so absolutely. So the problem with that is carbidopa, levodopa is generic, okay, and it's affordable. Carbidopa, levodopa controlled release is a little bit more expensive. Rytari, more expensive. That's the one that sort of gives you probably the least of them, that undulation of that line. And when you wind up doing a medication that's branded and not generic, there's a big price tag sometimes.
Yeah.
You know? And so some people will say, you know, I don't see a motor benefit to justify the cost. We'll get that. Or I see the motor benefit, but I can't afford it. So then I call on, there's different grant funding, or there's something called, we should actually probably give information for the chronic care collaborative too. There's different ways, different tricks that we have. Annie, are we supposed to end? Keep going? Okay.
Yeah.
Okay. We're almost done. I'm gonna breeze through this because again, you can do a whole lecture on each one of these things, but advanced therapies. So you're trying to hit between those, in that perfect on state and avoid the on with dyskinesias, avoid the offs. Sometimes people are gonna rely on advanced therapies, and we say advanced because it's not a pill anymore. It's requiring some sort of intervention or something that's invasive potentially. So deep brain stimulation therapy, deep brain stimulation surgery, duopa, which is levodopa through like a feeding tube, if you will. High frequency ultrasound, which I lovingly call non-invasive surgery. I'll tell you about that. And then subcutaneous levodopa, which is not yet approved. Oh yeah, so another myth, DBS is an experimental treatment. So DBS is not an experimental treatment. DBS is FDA approved since 1997. Okay, not experimental. It's part of my practice for helping folks with Parkinson's, essential tremor, dystonia, and other conditions. So we're gonna breeze through, but basically deep brain stimulation is the deep brain structures are stimulated by an electrical current that is derived from a sort of battery pack that's placed under the clavicle, the collarbone. All of the wires are underneath the skin, so you don't see anything. You'll see like a pacemaker sort of bump under the skin, and they're one on each side. And it helps even out those fluctuations. So folks who are stuck with fluctuations despite hammering in on medicine, despite some expensive medicines, we turn here. The intestinal gel infusion, basically it requires a surgical procedure to put in a tube The tube is connected to an infusion pump that a person will wear for usually 16 hours a day. They'll take it off. That tube will stay inside of their body, but they'll take off the infusion pump, go to bed, maybe take one pill at night, wake up, connect it, okay? The pump, if you can see in the gentleman's hand, it's kind of like the size of your palm. Kind of like this, but not as skinny. So it's not small, but it really helps some people. And then high frequency ultrasound, that is non-invasive surgery, right? So this doesn't totally make sense, non-invasive surgery. It uses a very high frequency focused ultrasound when a person's in an MRI scanner, so you need to be able to do an MRI. And you're awake in the MRI. And there's an ultrasound beam that's basically heating up a part of the brain to injure it on purpose, okay? And you may say, well, this sounds crazy, but actually this is what we did before DBS. So before DBS, people would have an open brain surgery to heat up a little part of the brain that would interrupt that abnormal circuit. And that's what Michael J. Fox had. He had that on what we call lesional therapy. And then came deep brain stimulation. And now high frequency ultrasound, it's getting better. It really is. People are getting more experience with this, and I'm more positive about it personally than maybe 5 years ago, if you will. But it's a new take on an old approach. Right now, it's only approved for unilateral treatment, meaning you can only do this treatment to one side of the brain and fix one body side. In Parkinson's, as the disease progresses, it doesn't stick on one side, right? So they're not, what about the other side? So there are studies that are going on to potentially look at using both sides, but not yet. It's not modifiable like DBS. Okay, I just leave you with the laundry list of all the places you can go for support, and that's it. Okay? We did it.